everybody. We are from Georgia. My name is George. I work with the Doctors of the World France mission in Georgia. So David will introduce probably himself. But before that, we are going to present the Georgian program, and how it will be arranged is that David will do the presentation of the program and what's going on, and I will focus more on the barriers. So, please.
Hello, my name is not George, I'm David. First of all, thank you very much for this opportunity to share our experience from Georgia. I represent Equality Movement. It's the biggest LGBT NGO in Georgia. We work in 5 cities in Georgia. And one of our main activity is HIV prevention. But because of the situation in Georgia right now, and in Georgia, Christian Orthodox Church is really, really powerful, and they have influence on every aspect, mainly in the country, it makes much harder and complicated to do our work. We have lots of violence outbursts every year. If, for example, Idaho or Pride is announced in the country, and basically we have to fight against homophobia and also think about HIV prevention. But we had this chance to start a new program, and the program is funded by the Global Fund. And it was in 2017 when we initiated and implemented this PrEP program. And it's divided in 2 parts. PrEP program is divided into parts. On the social side, we are responsible, Equality Movement, and on the clinical one, it's Georgian AIDS Center. From January 2020, we will take the full responsibility, and our community centers will be able to deliver, to distribute Truvada in its generic form to the community. And these are our target groups you can see on the screen. When we started this program, we had some kind of difficulties and barriers with the community because in Georgia we do not have really good prophylactic medical culture. And people always question initiatives such as PrEP because no one could understand why we were giving them some pills freely. And they had this question: we know that these pills are really expensive in Europe. Why are you giving us these pills free? So we had to think of different kind of communication strategies, and I will be talking in the next slides about these strategies. I forgot to show you the criteria which we are using for the community members to get involved in the program. I won't go through these points because I know I have little time. And basically what we do is that we are assessing the risk when someone comes to our community centers, or we are doing it in a field, for example, in cruising areas or in nightclubs, because right now in Georgia, nightlife is, we have a huge techno dance scene, and lots of community members can be found there. We are doing this assessment with scores, and if someone is eligible through this assessment process, then we are referring them to the AIDS Center for clinical research to find out if they are eligible clinically for the program. We started the program in 2017. Right now, our target is 300 people, and right now, 263 people are involved in the project, in the program, and they are getting Truvada. We had two cases when someone was infected with HIV during being on Truvada, but then when we made our investigation, we found out that they had quit. They had stopped taking the drug. Every medical procedure is for free of charge when someone wants to be in this program, and Giorgi will talk more about this clinical stuff. About this communication strategy, maybe you have already seen our leaflets and brochures. They are really, really explicit, and some people say it's too pornographic, but what we have found out is that nobody, and I mean nobody, ever reads brochures with lots of texts. They prefer to see pictures, and and we decided to show them these pictures. For example, I brought as an example these brochures. It's about HIV and fetishes. Because all the community knows that HIV is not transmitted through kissing or handshaking, but they do not know if it's transmitted through urinating or through rimming or fisting, maybe. So we decided to give them these kind of materials, and suddenly PrEP became cool. Suddenly people started posting pictures of themselves when they go to the AIDS center and taking this bottle of pills and sharing it on this biggest Facebook group we have. It's Hormone Night Community, associated to one of these queer party series, which I'm really proud of to be founder of it. So this made PrEP something really accessible and valuable for the community, and nowadays it became easier to reach out for the community. But unfortunately, and as it happens, there are some other NGOs who are working on HIV prevention in Georgia. And they had this issue that because you started delivering PrEP to the community, now STD risks will rise. So we decided to start new wave of campaign, and we are trying right now to inform the community that PrEP is not an alternative for the condom. It's just an additional layer of safety. And that's why we decided that our last campaign to be about STDs, and we use the same language to communicate with the community. Fortunately, both these campaigns seem to be really successful. From January, we are going to start new kind of campaigns, and we are still thinking about ideas because, as I told you, we are taking the whole responsibility. We will have a doctor at our office who would be able to do blood work at our office, and I will be. I want to tell you that I'm really anxious about this stuff because we do not have yet this kind of experience. But I hope everything will be fine, and our community centers will be fully equipped to provide all these medical services to the community. Thank you very much. I think Giorgi now will continue with different kind of barriers we had.
You know how okay. Yeah. So hello again. Basically, as David mentioned, the demonstration project of PrEP in Georgia started back in 2017. It was around a year-and-a-half demonstration project, and the arrangement of the project was that there were two parties involved in the implementation. So it was the clinical part, which was administered by the AIDS Center, and the social part, which consisted of the adherence counseling, risk reduction counseling, and social support. It was administered by the community-based organization. So after the demonstration project, we did a survey. Actually, it was not a survey, it was more programmatic assessment to look inside what went well and what didn't, and how we can improve the program and what are the barriers that are limiting people's access to the services. So basically, Okay, yeah. So basically what we did was the mixed methodology. We did the focus group discussions, in total 7. And the design of this focus group discussions was to engage the people who are already enrolled in PrEP on one hand, and the people who are potential PrEP users on another hand. We had the key informant interviews with stakeholders working in the field to see how we can use the network of partners to facilitate and improve the recruitment process. And also we had the online questionnaire. Basically, I will bring here the overall, I will not dive very much into details, and we'll be happy to discuss it one-on-one, but the basic data, which was from the online survey and focus group discussions, it is important to understand what is the demographic profile of our beneficiaries and how we can facilitate and how we can facilitate their better access. So basically, the age group is around from 80 to 30 years old, and around half of it is aged 18-24. Around 43% have the higher education, which is very important, and around half, a little bit more than half, are employed. Though it is important to state that out of the participants who took part in the online survey and focus group discussions, only 10% of those who were from the regions were employed. And the average income for all the participants was around from 160 to 300 US dollars per month. And what was notable that around half of them still live with the parents, and obviously it was one of the challenge which was brought up as the barrier to adherence, because most of them were hiding the fact that they are taking the PrEP. So in sense of behavior, the sexual contact with a female partner among cis MSM who took part in the study was reported only by one person. Around 23% reported to have 10 or more sexual partners during last 10 months, last month, I'm sorry. What is very funny is 666, like the devil, reported the use of the drugs, which is important data linking to the chemsex behavior and comparing it to the IBBS data that we have in the country, though IBBS also demonstrates the increase in the drug use among MSM population, there is a big difference in this data, so we have here the bit more. Experience of the group sex practices in a lifetime was reported by 75%. And the sexual intercourse under the influence of the psychoactive substances, both drugs or alcohol, was reported by a bit more than half of the people. And what is notable is that the condom use decreases with the sexual intercourse while under the influence of the psychoactive substances. Okay. Basically, what we found out is not something new, which is alarming, because we'll continue to have the same mistakes that we've had in the HIV treatment and care programs for the many years. And we divide it into the 3 directions, let's say. On one hand, it's the social barriers. And social barriers, David talked about the overall homophobia and the stigma and discrimination. I would like to focus here more on the institutionalized stigma, which is the big case on the different levels, including the medical facility, the National AIDS Center, who is providing the PrEP, prescribing the PrEP services. And what is very interesting that during the focus group discussions, there were some people who were saying that as we are provided with the information about the side effects of the medications, we should be provided about the environment that we will have in the AIDS center when we go there for the PrEP. So there is the huge issues with the monopolization of the HIV services in country by AIDS center. On the other hand, there is the program-related barriers, which on one hand is the over-medicalization of services and lack of the meaningful participation of the peers throughout the pathways of the PrEP service delivery. There is lack of diversity because there are many people who don't want simply to go to the AIDS center. So there is a lack of diversity of outlets, and we're pushing a lot to introduce the community-provided PrEP, and hopefully it will soon start, I think so. Then there is the financial and geographical access, and what we need to understand in this case that the fact that the drugs itself are free of charge doesn't ensure the financial or physical access to people, because there are many like issues around like the geographical access, cost for transportation, and considering the general social and economical conditions of the people, it might be physically available in the central city, but people are not able to go there to get it due to the many reasons. Then there is the issue that we lack the integral approach. For example, when we work with the people who have the different behavioral patterns, like for instance, the engaged in chemsex or drug use. On one hand, there is the harm reduction program for the drug use, which totally ignores the specifics of the LGBT community. Then there is total ignorance of the use of the non-injecting drugs, which is due to the Global Fund programming. And what we need to focus is to think how we can tailor whatever resources we have in the country, considering the limited resources and phasing out of the Global Fund, to benefit for the different populations of the communities. So, and what is the most important part is the, let's say, resources and the support for the program and sustainability barriers, which is, as I mentioned, the Global Fund is the only source for the programs targeted to key populations, including the overall prevention programs for the MSM population. For now, the government is covering some costs for the medications, though the biggest concern is about the political will and the environment in the country and the readiness of the government to invest into the programs targeted for MSM, drug users, or sex workers. And together with the physical availability and allocation of the resources by the government, there is issue in the modeling. So how the government will design the programs, and if the community role will be at least sustained at the same level that we have now, or we have the fears that it will be totally, again, over-medicalized and integrated into the medical facilities with total ignorance of the role and the functions of the community. So basically that's it. I'm sorry it was a bit general, so I would be happy to talk about some details and share with you the document later on.
Thanks.